And our last lecture in this respiratory package, Lecture 7, is on troubleshooting. And this lecture will be delivered by Dr. Laura Galazzara Baccarina, and she will present how to recognise the deteriorating respiratory patient using clinical and alarm signs and identifying basic techniques for managing that deterioration. So welcome, Laura.
Thanks, Una. Hello and welcome to this session on troubleshooting inside their chapter of Basics of Respiratory Support. It's an honor to deliver this session inside the C19 space, and I hope you'll find this session really useful. After this session, you should be able to recognize the deteriorating respiratory patient using clinical and alarm signs and adopt some basic respiratory management techniques in the deteriorating respiratory patient. In ICU, we could find 3 different types of patients with respiratory support. On one side, awake patients with high-flow nasal cannula or non-invasive mechanical ventilation. On the other side, sedated and invasively mechanical ventilated patient, and in the middle, awake invasively mechanical ventilated patient, which have things in common with both patient groups. We will start with the awake patient. An awake patient usually complains before an alarm beeps. That's a characteristic that differentiates them from sedated patients. We could see the following symptoms. The patient will complain of shortness of breath, or as we sometimes call it, the patient has some air hunger, which is a sensation of not being able to breathe in sufficient air. The patient could have some bluish skin or fingernails and have a fast or labored breathing, with use of accessory muscles such as the scalene or the trapezius, with retraction or flaring of the nostrils, or with a characteristic position consisting of sitting up in bed and leaning forward slightly. The signs of a patient with troubles breathing that we could see in the bedside monitor are tachypnea with more than 24 breaths per minute, tachycardia with more than 100 beats per minute, a decrease in oxygen saturation, or an increase in blood pressure. We should keep in mind that it's not compulsory to have all of them. We can just find 1 or 2 in our patient. And what should I do when a patient is respiratory deteriorating? We should always stay with the patient during this acute episode that will make them less anxious. We should talk to the patient, ask them what happens, and try to reassure them. And if the patient is using non-invasive mechanical ventilation or mechanical ventilation, we should check the interface and the circuit, and also look at the machine, at the ventilator. It will show some alarms that can give you clues of what's happening, but we will review the alarms a little bit later. Sometimes the problem is with the machine and not with the patient per se, so we have to keep that in mind too. And what else should I do? We should place the patient with a proper body alignment. A sitting position will permit a maximum lung excursion and a chest expansion. We should encourage sustained deep breaths. This maneuver will decrease their anxiety and also improve their oxygenation. We should ask if he or she has some secretions, and if the answer is affirmative, we should encourage coughing or suction if the patient is intubated. We should provide some respiratory medications such as bronchodilator and oxygen, but always per doctor's order. And also, sometimes, mostly if the oxygen saturation isn't decreasing, we should also look for other causes that may mimic the signs and symptoms. Is the patient anxious or in pain? Does he have some fever? So with all this, did I solve the problem? Yes, so that's perfect. Just reassure your patient that everything's gonna be all right, that you are just with him, and keep monitor his or her vital signs. If we can't solve the problem, we should call for help because the patient may be deteriorating and needs some other medication or even intubation. You should also increase the oxygen while waiting for help. Now we will change to a deeply sedated and invasively mechanical ventilated patient. The most important characteristic of this patient is that they will not talk or complain, so we have to rely on alarms to figure out what's happening. There's two types of alarms, the ones from the bedside monitor and the ones from the ventilator. Alarms alert the staff of changes in patient's condition that requires our attention. So check all your alarms that they are active and clearly audible, not only at the beginning of your shift, but also when taking over a new patient. You should never, ever silence an alarm unless you know what it means and can respond appropriately. And you should call for help if an alarm sounds and you do not know how to respond to it. So what to do when you hear an alarm? You should go to your patient's room and check the patient. We should check the bedside monitor for tachycardia, a decrease in oxygen saturation, or a blood pressure increase. You may have noticed that I said nothing about the respiratory rate this time, and that's because in these deeply sedated patients and sometimes also neuromuscular blocking agents, we won't see tachypnea because they aren't able to breathe and the ventilator is in a controlled mode. We should also check if the patient is cyanosed. Is the chest moving? Sometimes there's a disconnection in the ventilator circuit, or the ventilator is malfunctioning and the chest is not moving. And if the chest is moving, we should check if it's moving symmetrical. For instance, when there's a selective intubation or a pneumothorax, we will see a symmetrical movement of the thorax. And after checking with our patient, we should identify the alarm and silence it. And why should we silence it? That's because a constant beeping will distract us from thinking, which is our next step. We should always think before we act. Is this an urgent problem? Is my patient unstable? Should I call for help right now? Do I have a patient's problem? Or on the contrary, I think it's an equipment problem. So whether it's a problem with the patient or the ventilator, we should always have the same routine. Can I solve the problem? Yes, do it. No, I can solve it. Just call for help and disconnect the patient from the ventilator and manually ventilate using a self-inflating resuscitator bag. This can be not allowed for non-ICU nurses in some countries or units. So you have to check in your unit if you are allowed to do it, or you should assist a senior nurse or a doctor in manually ventilating the patient. A couple of tips that will make you a little bit anxious is that you should know your ventilator. Each ventilator has different sounds and different names for the same alarms, but you will get used to them once you are working there. And also, the ventilator and circuit problems can be distinguished from endotracheal tube and patient's problems by taking off the ventilator and manually bagging the patient. And while we're manually ventilating the patient, we could assess the feel of the lungs. Is it difficult to ventilate the patient? If that's the case, the problem is usually with the endotracheal tube or with the patient. But on the other side, if we can manually ventilate it really easily, the problem should most of the times is with the ventilator or the circuit. So far, we have talked about checking the patients and bedside monitor alarms. So now we will review the most common ventilator alarms and what to do with them. These alarms can be seen in non-invasive and invasive ventilators. But don't be afraid, neither is scary. I'll try to make them as simple as possible. The most common alarm is the high airway pressure. Here in this picture, you can see that there's three waveforms: the pressure, the flow, and the volume over time. In the pressure part, we see in the first couple of breaths, you see that there's a peak and a plateau, and after the third one is just a peak. And consequently, there's a decrease in the volume that you can see in the last waveform. And all this is because many ventilators cycle from inspiration to expiration immediately if the upper pressure alarm limit is reached. And as a result, the inspiration is terminated early and the tidal volume is reduced. The causes of this alarm are various. We could see it in ventilator problems. Maybe there's an excessive tidal volume or flow, or the ventilator is malfunctioning. Maybe there's some problem with the circuit. There's some fluid pooling in the circuit of the filter. There's some kinking of the circuit. There's dirty bacteria filters or overly wet head and moisture exchanger. If one of this is the case of this alarm, we should beg the patient while a colleague change what is needed to be done. We could also see this alarm when there's an endotracheal tube obstruction, maybe some mucus, some bleeding from the patient. So in the first case, we need to suction him or her. And on the second case, we can use a soft bite block or consider if the patient needs a little bit more sedation. We could also see this alarm when there's an increased airway resistance, for instance, in bronchospasm. And in these cases, we can administer a bronchodilator after consulting with a doctor or a senior nurse. Maybe the patient is coughing because it has some secretion, the patient is agitated, or even has some patient ventilator dysynchrony, or as we sometimes call it, the patient is fighting the ventilator. In these cases, we should look for the cause for this dysynchrony and try, if we can solve it, to sedate a little bit heavily our patient. Another cause for this alarm is a decrease in the respiratory compliance. It can be seen when there's a selective intubation or a pneumothorax, but also when our patient is worsening at the respiratory tract. Now we will change to the low airway pressure, low volume or leak alarm. This alarm is seen when there's a disconnection somewhere in the ventilator circuit or an inadequate inflation of the tube cuff. We should check if the patient is connected at the tract side. Are the closed suction systems or the inline suction system, as you call it, as the head and moisture exchanger connection and at the filter. We should check the endotracheal tube position. Is the depth the same as before? Has it been dislodged during transport or during prone? Is my cuff pressure okay? Should I need to increase it, or maybe the endotracheal tube needs to be replaced because the cuff is not properly inflating? And also, when our patient is using a non-invasive mechanical ventilator, we should check the interface. Here, we can see that there's no pressure waveform on the upper side, and we have a clear disconnection in the inspiratory limb. That's a problem that we can solve right away. We don't need to bug the patient to solve this problem. In case of non-invasive mechanical ventilators, We should always try to choose the correct interface and size for our patient to avoid leakage in the interface. We should check it fits properly and tighten the straps more than we can, but always think that sometimes they will get some nasal pressures. Some ventilators also has some air leak compensatory systems, so we can use it if we have them in our unit. Another alarm is the high tidal volume or changing volumes alarms, which is frequently seen in awaking patients that maybe need some more sedation or completely hold it. And also when there's an inline nebulizer in the circuit. In the image, we can see these small peaks in the inspiratory part of the pressure wave, and this can be seen when there's something in the circuit, for instance, some water, or when there are secretions. Our last alarm is the apnea alarm that it's only seen in spontaneous breathing patients. 50 to 20 seconds after the last breath, if the patient is not breathing again, the ventilator will change into a controlled mode as a secure measure. We should check our patient and assess why he's not breathing. Maybe he still has some sedation, or maybe the patient is deteriorating. Nevertheless, if we want to return to the spontaneous breathing mode, we should press the reset button. If not, the machine will go on and on and on within the control mode. Other alarm information. There are many other alarms. If you are unfamiliar with them, contact a colleague. I'm sure they will be glad to help you. And also, you don't have to worry if there's an alarm warning in the ventilator screen, please, but there's no audible alarm. Ventilators display the last alarm activated, so you just have to reset the button for the next one. Now, we will move on to the last part of our presentation, which is about the ventilator care bundle. A bundle is a group of interventions related to a disease process that, when executed together, results in better outcomes than when implemented individually. In the case of the ventilator care bundle, it's willing to decrease the incidence of ventilator-associated pneumonia, and it has 5 components: the elevation of head bed, the daily sedation interruption, peptic ulcer or deep venous prophylaxis, and the mouth care. But we will talk about them separately. The first one is the head of the bed should be between 30 and 45 degrees to prevent aspiration of gastric content. The second one is the daily sedation hold to assess the readiness to extubate our patient, with the purpose to prevent oversedation and reduce the duration of mechanical ventilation and the length of stay. This measure is desirable in every patient, but it's not always possible, mostly at the beginning of their stay in our unit, because of their condition. We want whole sedation in paralyzed patients, in neurological patients with high intracranial pressure, or in respiratory patients with great needs of PEEP and FiO2. The peptic ulcer prophylaxis will minimize the risk of ulcers and bleeding, and consequently decrease the length of stay in our unit. The prophylaxis of deep venous thrombosis with mechanical methods, such as intermittent leg compression or with pharmacological agents, will minimize the risk of venous thrombosis and decrease the length of stay. Here you can see there's a thrombosis in the femoral vein. The last one is the oral care with subglottic aspiration if it's possible. This intervention will minimize the risk of microaspirations, but always remember that before oral care, you should assess the proper cough infection. Maybe at this point, you are thinking that that's too much information for you. So for your first day in the ICU, just remember this mnemonic on causes for a ventilator alarm. Displacement 2 on the tracheal tube cuff not inflated. Obstruction of the endotracheal tube, maybe some mucus, beating, or kinking. A pneumothorax. An equipment malfunction or stacked breath that can be seen in asthmatic patients or when there's a patient ventilatory dysynchrony. And always remember the routine that we have learned. Can I solve the problem? Yes. So just reassure our patient and keep monitoring his or her vital signs. If not, call for help and disconnect the patient and manually ventilate it using a self-inflector bags. And also try to think some causes. Maybe there's a kinking in the circuit, there's a mucus plug, or a tube migration. Here's some bibliography that you can use, maybe it's useful for you. Thank you very much for your time, and I hope you enjoyed this session.
So thank you, Laura. A really great talk to end our series of lectures on respiratory, the basics of respiratory support in ICU, and lots of really good practical tips and ideas and advice for staff within that. So some of the questions I was thinking about would be, so if I were a new nurse in ICU, not very sure of myself, and was obviously observing my patient, noticing that my patient who's ventilated is becoming increasingly restless. The ventilator's starting to alarm high airway pressure and the patient's oxygen saturations are falling. This is a little bit overwhelming for me, trying to take it all in and think, well, what's going on here? What should I do?
Well, we should try to do always the same routine, no matter what alarm is. You should go to your patient's room and check for the signs and symptoms that we have learned today. We should recognize the alarm and silence it. If there's an obvious cause for this alarm, maybe there's some kind of kinking, there's a disconnection somewhere, we can try to just fix it. And if the oxygen saturation is decreasing or falling and we can solve the problem right away, we should call for help and manually ventilate the patient, if you are allowed to do it in your ICU. If not, just assist the senior nurse or the doctor. And while manually ventilating the patient, always try to rule out patient's problem first. There's some secretion, there's a bronchospasm, a selective intubation, is the patient coughing or delirious? And maybe while you are thinking, probably the senior nurse and the doctor are also there and trying also to solve it. But if you are alone, because there's a lot of work in other places, then try to rule out some other problems with the ventilator. There's some dirty filters, there's water in the circuit, and probably with all the causes that we had learned today, you can solve almost 90% of the cases.
Yes, that's really good advice, Laura, and really reassuring for many of those nurses coming to work in ICU to know, that they'll work within their scope of practice. They'll not be expected to take on something that they're not sure about, and that the senior team are there to support them with that. So I'm just thinking for any of the medical staff or the senior nursing staff or maybe some senior physiotherapists perhaps who are undertaking manual ventilation, is there anything they need to think about and be careful about during this COVID period and with infection risks in general when they are manually ventilating patients?
Yeah, well, there's some things that they had to take in mind. I'm pretty sure they will be using their protective clothes, the glasses, the mask and everything, but you need to try to put always a filter between the patient tube and the bag, and try to manually ventilate as less time as possible to decrease the dispersion of the COVID-19. But sometimes you have to do it, and if you are well protected, for instance, in our unit, we seen there's no problem. We see no nurse, not a doctor, to get COVID-19 from these measures. But you need to be careful with them, sure.
Yeah. And then, Laura, my final question, as a medical doctor, what advice would you give to a non-ICU nurse on his or her first day in the ICU when encountering a deteriorating respiratory patient?
Well, the first day in the ICU is really scary. It was for me the first day maybe 10 years ago. But unlike regular wards or normal ward, you are never alone. In the ICU, we are a team, and that's really reassuring for me. I mean, on your first day, you should take some time during your first day to know exactly, for instance, where the CPR trolley is, and also complete a bedside check at the beginning of your shift, as Jonathan, I think, explained it before, to know exactly where everything is in case something goes bad. If during your first shift you have a patient that is deteriorating, just stay calm and take it easy. I mean, if you remember this session and know the routine, that's perfect. But if not, call for help, increase the oxygen while waiting. And as I said before, we are a team. Nobody expects from you to know everything on your first shift. So just take your time. You will improve with the time.
Thank you, Laura. That's really reassuring and a really lovely way to end. And I'm sure all of the nurses who engage and participate now in these lectures will find that very comforting and very helpful. So thank you again for an excellent talk.
Thank you, too.